I'll start with the strategic direction. Please note that the strategy in question that I'm going to be speaking to is the one that runs from 2021 to 2025. It follows another one that was named the Uganda Malaria Reduction Strategic Plan of 2015-2025. 2015-2020. And when that one ended, because remember, all division and department strategic plans have to be aligned to the Ministry of Health strategic plans, the different periods. Right now, we are serving into the Ministry of Health strategic plan of 2021-2025. So when the 2015-2020 one expired, and the name of that one was the Uganda Malaria Reduction Strategic Plan. Why? Because then at that time, the country had a very high burden of malaria, and we couldn't speak to elimination. All we could speak to was reduction for all parts of Uganda. So when that expired, but please note that as we implemented that, we did a mid-term review. But as it also expired, we did a progress review, and it is from the progress review that we actually got recommendations that were eventually adopted as key actions under this new one that is named the Uganda Malaria Reduction and Elimination Plan 2021-2025. So at that time we started planning, the population targeted was about 44. And from the previous strategic plan and the review, we picked some of these key findings. That one, still the children under 5 and pregnant women, the non-immune visitors, or call them travelers, people living with HIV/AIDS were the most vulnerable to malaria. And that is a very, very important point. Because remember, our strategic plan premises a lot on equity and equality and making sure that we reach the vulnerable groups, as you will see later in our strategic objectives. And so we also noted that the different surveys were indicating that actually the picture of malaria was changing from the bullet to that I highlighted before, that we were beginning to get more children 5 to 15 years, especially in areas where malaria burden had greatly reduced. The likes of Kampala, the peri-urban areas were beginning to get, but also in other populations, because most of these other interventions targeted the vulnerable groups mentioned above, that were beginning to get this sort of neglected age group of 5 to 15 years, reporting more cases of malaria, including severe forms of malaria. And Bullet 4 speaks to the variation in the burden. And it's actually, this point here actually is one of the reasons why you may realize that our new plan is named the Uganda Malaria Reduction and Elimination Strategic Plan. Because of this variation, you can't have the same strategies everywhere. It can't be a one shoe fit all. Some places need stronger strategies and a bigger package of strategies, while others may need well thought through but fewer strategies. As you may see clearly here, Kampala and Kigezi had a malaria parasite prevalence of less than 1%, while Karamoja and West Nile and Busoga had slightly higher. And please note that Karamoja had the highest at 34%. And the other key thing to note is the loss of immunity amongst the population where you have low transmission, like where you're seeing Kampala and Kigezi, especially Kampala. If for some of you who stay in Kampala here, you could have noted that some of your children have never suffered malaria. And so because they've never been exposed, even the exposure they had intrauteri is lost around the age of 6 months. And from that time, if they never suffer from malaria, they lose their immunity. And so not only Kampala, but you're also going to see in the map there that there are quite a number of districts, about 27%, where there is low transmission of malaria, and so immunity has been lost, and such places are likely to have severe forms of malaria. The general prevalence at that time was noted to be about 9%. That is 2019, but this had dropped from 19% in 2014, and the one of 2014 had dropped from 42% in 2009. So meaning that a lot has been done to reduce the parasites within the population. So clearly the map here tries to show us the different parasite prevalence. If I can speak to the last bullet, when you say 9% nationally, it means that every other time you meet 100 Ugandans, 9 of them may be carrying malaria parasites. And in Kampala, when you meet 100, less than 1 may be carrying malaria parasites, especially depending on where you are. But when you go to Karamoja and meet 100 Karamajongs, 34 of them could be carrying malaria parasites. So the map you're seeing here is showing us the different pictures. Please note that following Karamoja, we have West Nile at 22, and then immediately following is Busoga. Meaning that in Busoga, every other time you meet 100 people in the Busoga region, 21 of them could be carrying malaria parasites. And so you're seeing the kind of challenge we are having, and the map on the other side is trying to show us the percentages. I think you're seeing where most of our burden is coming from per district. And so based on that, we designed a strategic plan. The vision is to see a malaria-free Uganda that can facilitate a socio-economic transformation in line with the vision to 2040. Clearly, if you look at poverty and malaria, they are very synonymous. Where you're having lots of malaria, you have a lot of poverty. And where you're having a lot of poverty, you'll have a lot of malaria. So for you to reduce the burden of malaria, you need to improve the socioeconomic status. But for you to improve the socioeconomic status, you need to reduce the burden of malaria. So if you looked at our strategic plan, a family spends around $9 even when the medicines are free. Every other time a member of that family has a malaria episode. Now imagine if you have 4 of them, and in a year you suffer 3 episodes. How much money are you losing? And the mission is to provide quality assured services for malaria prevention and treatment to all people in Uganda, so that you facilitate the attainment of good standard of health that will effectively contribute to the national development. I think this mission is very, very clear. It's not for just provision of services, but they should be quality. Whenever you're doing malaria prevention and treatment service delivery, it should be quality and it should be reaching all people. Because when you reach all people, then you're going to facilitate the attainment of good health, and health people will be more productive and there'll be more development. So you'll be contributing to the socioeconomic development of the country, and probably you'll be contributing to the attainment of a middle income status come 2040. So our Uganda Malaria Reduction and Elimination Strategic Plan has this ambitious goal. And for me, if at least someone can remember this goal as they live here today, they would have done me a very good service, because I believe it will be a good driving factor. By 2025, we must have reduced the malaria infection and morbidity by 50%. Of the 2019 levels, I am unfortunately going to not to be able to show you those levels, but you can look back at your health facility and ask yourself, what were my 2019 levels of cases of OPD attendance, cases of severe malaria admissions, and I must reduce this by 50%. The other is we must reduce malaria-related mortality by 75%. This is a very ambitious target, and that's why we're going to speak a lot to severe malaria management. And so we have about 6 strategic objectives. And please note that it's in strategic objective 1, where we are having actually malaria case management. And here we want to accelerate access to malaria preventive and curative services to achieve a universal coverage in all eligible populations by 2025. By 2025, every curative service, that is case management, should be reaching every Ugandan wherever they are. But also the preventive services, that is the mosquito nets, the IPTP that we talked about last time, they should be reaching everyone by 2025. So we have to accelerate our efforts. It starts all the way from the individual. Are you seeking the care? From the head of the house, are you seeking the care? From the leader of the village, are you supporting your village to seek care in time? All of them. And then it goes through all of us up to us at the Ministry of Health. Then strategic objective 2, we want to, by 2025 to have established a system for malaria elimination in the targeted districts. And so far, when you look back at that map, the targeted districts for elimination are majorly Kampala and Kabale and Mbale. We want to have eliminated malaria by 2025 in those targeted districts. Probably some more will come up as we go along. Strategic objective 3, we want to enhance quality of care of malaria services in at least 80% of the private health facilities, managing malaria according to the national guidelines and reporting quality data by 2025. We want to make sure that at least 80% of the private health facilities are following guidelines as they are managing malaria, and they are giving us quality data. This is very important. Remember, last time someone asked this, and I told them we have a standalone strategic objective for this. The team has composed a strategic plan to achieve this objective, and they have different guidelines for making sure that this is achieved. And they've put in place a number of actions. Strategic objective 4, by 2025, at least 90% of the population sustains the acquired knowledge, utilizes and practices correct malaria management, preventive and curative services. You know what has been happening? The messages go out there, people hear them, they dance to the music or they read the leaflet, throw it there. It doesn't translate into practice. It doesn't translate into a behavior. So by all this, what we want to see is a behavior, a changed behavior. We want to see a changed practice. It shouldn't stop at knowledge only. Someone knows, yes, they know, but they don't translate the knowledge into practice. Having knowledge is one thing, but translating it into practice, a practice that eventually will translate into a changed behavior that someone will see, that someone used not to use a mosquito net, but here now they use it every day. Someone used to take 48 hours before seeking treatment, but now they seek treatment within 1 hour of feeling unwell. And this is what they do anytime they are sick. It's a sustained practice. When someone is sick in their house, they take them to hospital immediately. These are some of the things we need to see. Then number 5 is by 2025, decisions for malaria programming at all levels should be guided by a functional and comprehensive surveillance system and data repository for effective subnational response monitoring and evaluation, as well as priority operational research. Members, let's speak interest in research. Let's speak in interest in using our data. Let's be the very first people to use our data. But the practice right now is that because the district wants your report, you simply relay it and transmit it without you first analyzing your data and understanding your problems, so that you're the first one to detect gaps and you act on them. And then you keep waiting for feedback from us, which we at times also never give. So we need to start using data for decision making. We need to pick interest in using data to do research and a number of other things. By 2025, 80% of the districts will have a strengthened enabling environment that will be helping them to deliver malaria interventions and measure progress. This should go all the way up to facility level. So having said that about the strategic direction, clearly we know the mission, we know the vision, mission, goal, and strategic objectives. I don't want to go beyond this, but if someone can clearly understand for me the vision, mission, and the goal, the strategic objectives you can keep revisiting. Pick one, like the one of case management on the curative side, and at least remember that at least in whatever I do, I should make sure that everyone is reached with quality services of case management. So now this takes us to key highlights of the policy, especially around malaria case management. The policy for the section of, the goal for the section of case management in the policy is to significantly reduce morbidity and prevent mortality that is attributable to malaria, and eventually interrupt transmission. Members, we need to understand this goal. Every other time you work, try to see that you reduce the number of people attending attending OPD due to malaria. You reduce the number of people being admitted because of malaria. But more so, you don't let anyone die of malaria. Actually, by 2025, less than 1 per 100,000 people should be dying of malaria, meaning that 0 people should be dying of malaria. And we know that if people are coming into hospital on time because you've talked to them, and you're monitoring your stocks, and always you report stockouts, and you're quantifying properly so medicines are usually available, and you're encouraging your patients to come on time, and they are getting the treatment and they're not going back to the community with malaria parasites, then you're interrupting transmission, you're reducing the number of cases. This is the key thing. But also, the objectives under case management, we want to be sure that there is early diagnosis and prompt effective treatment of malaria in both the public and private sector setting. That is done according to the national treatment guidelines. Someone has just been telling me today that there is a pregnant woman who died. Why? They gave them IV artesunate loading dose, and they gave them a dose of Fancida to continue with home. The next time the mother came back, she had PV bleeding, there was no blood, the mother died. So that is not being treatment according to the WHO and national treatment guidelines. The guidelines are saying something different, as we're going to see later. We also want to ensure that all suspected malaria cases are subjected to a quality assured standard parasitological test. That is either a malaria rapid diagnostic test or a all microscopy, blood slide. And blood microscopy remains the gold standard. I know there are others like PCR, but those are because you know when you're picking on a test, it should be giving you good, quality results, but then it should also be affordable for your setting. Then we want to ensure availability of quality assured diagnostics and malaria treatments in both the public and private sector. Then we want to ensure that all malaria cases are properly documented at all points of care, including the community. We want to provide testing and treatment for asymptomatic or low density malaria cases. This is an objective because, like I said last time, we're beginning to get increasing numbers of asymptomatic malaria. They want to be sure that complications of malaria, including black water fever that is becoming very common, are effectively managed both in the public and private sector and according to the provided protocols and guidelines. These are some of the objectives under the policy. In the policy, and actually this policy we are speaking to is the National Malaria Reduction and Elimination Policy of 2018. It's available. I think some of you could have accessed it, but it has a number of other sections. But like I said, I'm going to share the rest of the slides. I mean the slides so that you can be able to check the other sections that are not case management. So remember, we emphasized that it should be prompt diagnosis and treatment. So the diagnostics here we are talking to malaria RDTs are going that will be used at all levels: community, health center 2, health center 3, and all levels of service delivery. But we prefer that for higher levels like district hospital, regional referral hospital, that we try to really use microscopy because it remains the gold standard. Then what is the treatment that is recommended by WHO and Ministry of Health? As we speak, the first line treatment remains an SCT. SCT means artemisinin combination therapies, artemisinin based. In that combination, there should be an artemisinin, and the artemisinins include the following: artemether, artesunate, dihydroartemisinin, piperaquine, combined with another antimalarial that has a different mode of action. Like artemether is combined with lumefantrine, artesunate is combined with amodiaquine, and then dihydroartemisinin is combined with piperaquine, I beg your pardon. So the first and second line SCTs will be reviewed according to the therapeutic efficacy studies. Like I mentioned earlier, globally they are beginning to document increasing levels of SCT resistance. And I think the last therapeutic efficacy study picked some amount of resistance in the areas of Busia and to some extent, I think, West Nile. For now, they are being documented as delayed parasite clearance as further therapeutic studies are done for us to know, to confirm if these are really treatment failures. But even when we do realize that it's actually treatment failure, we may not quickly review treatment until we are at a certain level of resistance. So another thing we need to note that you remember when they first introduced SCTs, the guidance was that we were not supposed to use SCTs for children that were 5 kilograms and below, including the neonates. But now the guidance is that you can actually use SCTs in the children that are 5 kilograms, the infants. You use the same dose as that of the category of 5 to less than 14 kilograms. So they do 1 tablet. So, but also, one of the things that we've been further guided to do is that as countries procure SCTs for children, they should endeavor to procure child-friendly formulations, especially the flavored dispersible tablets, because then it got so cumbersome for mothers to keep crushing, and there was wastage, there was improper administration. So other things that have been recommended under the new policy is the deployment of interventions like mass drug administration where they are needed, mass screening and testing, fever screening and testing, and this, as you do, you should follow WHO guidelines. Then we also know that we are doing integrated community case management in areas where access is hard and where we have hotspots. But then we're also planning to bring on board because remember this ICCM was mainly targeting children under 5, but now we want, and the objectives of this are to reduce cases of severe malaria, but also to reduce malaria mortality. Because access is what will facilitate the progress to severe malaria, but then it will also facilitate death. So that's why you'd want to do ICCM. But now we are planning to actually scale up to the age group of more than 5, as you saw in our strategy. There we're beginning to get more children, 5 to 15. So want to actually start doing community case management. So for severe malaria, the preferred treatment is injectable artesunate given as IV or IM, or but I also know that there are alternatives like injectable quinine and injectable artemether. Rectal artesunate is the recommended pre-referral treatment for children 5 years and below. Then the adults or older children will still do IM artemether or IM artesunate, artemether or quinine as their pre-referral treatment. There was evidence that actually rectatisonate does not do well for patients above 5 years. And that's because, remember, previously we were doing rectatisonate for everyone, but evidence came through that actually older people were not responding well to rectatisonate. So still referral treatment continues. Rectatisonate not be used. I've spoken to this already. Where referral is not possible, continue pre-referral treatment, as in you can continue doing rectatisonate until a patient is able to tolerate oral treatment, then you change them to a full course of an ACT. Then we have another set of things coming into the new policy. For example, remember, for a very long time, the only formal chemo prevention that was being done was intermittent preventive treatment of malaria in pregnancy. But now we're being encouraged to introduce other chemo preventive approaches as co-interventions for malaria prevention. So we want to explore the possibility of using intermittent preventive treatment of malaria in infants. But the new WHO guidelines have changed the name of this intermittent preventive treatment of malaria in infants. It's now being referred to as the perennial malaria chemo prevention. This intermittent preventive treatment of malaria in infants was previously targeting children below 12 years, but now having changed to perennial malaria chemo prevention, it's going to be targeting children below 24 months of age. The drug of choice remains sulfadoxine pyrimethamine, that is Fancida, and we shall still use the platform of UNEPI because these children come for immunization. Then we have intermittent preventive treatment of malaria in children. This is previously was targeting all those children above 1 year. But now the new WHO guidelines are referring to it as either intermittent preventive treatment of malaria in schools, because with the universal primary and secondary education, we expect the majority of the children should be going to school. And because you know that this universal primary and secondary education is not a Uganda thing, it's an SDG thing. So, instead of the intermittent preventive treatment of malaria in schools, in children, you're going to see that we are speaking to the intermittent preventive treatment of malaria in schools. Here we may use dihydroartemisinin and piperacin because some studies have already done this, but the molecules to use are still being discussed because there's also SPARC. So this IPTC has also another component of seasonal malaria chemo prevention. Previously, in the old guidelines, seasonal malaria chemo prevention was the intermittent administration of a full course of an antimalarial that would be given during the period of high transmission to prevent severe malaria cases and death among the high-risk groups. And it had to be implemented in an area that is highly seasonal, an area where you know that in this season the rains are at their maximum and the transmission is at its maximum. So we go in and give children medication, like the Sahel region in West Africa. Here, the region in Uganda that measures up to the Sahel is Karamoja. There was evidence coming through that actually Karamoja has one prolonged rainfall season that starts around May and ends around October. And so during that time, the transmission is high. And that is why you see for us in Uganda, we started from 2021 to implement seasonal malaria chemo prevention in Karamoja. We did a pilot, the results were good, and now we're in the process of scaling up as we evaluate a number of other things. So in here, we have the intermittent preventive treatment of malaria in schools and seasonal malaria chemo prevention. Then chemoprophylaxis. In the policy, we are saying we are going to be doing chemoprophylaxis to the non-immune travelers and internal travelers from low transmission to high transmission. And the drug options include mefloquine, that is done daily, atovaquone proguanil, and then doxycycline. Atovaquone proguanil, I think, is commonly called Malaria. But please note that doxycycline is not recommended for children below 12 years, so it can't be used in the children. It's for only adults. Then in sickle cell anemia, you know that the SP is being used, sulfadoxine pyrimethamine, but also chloroquine is something else you can use. But please note there are two things around here. Sulfadoxine pyrimethamine, you know that its efficacy is interfered with when you use it together with high doses of folic acid, especially if the strength of folic acid is above 2.5 milligrams. And you know that our sicklers are usually on 5 milligrams daily of folic acid. So the question is this being effective, or we encourage in the guideline that you give them and then you give them a break of 7 days. But then also the other thing we need to explore as researchers, what is the folic acid need among sicklers? Could it be that they can even do with a lower dose, and so that even if you give them SP, they will do well? But also a number of studies are being done to explore other alternatives like DP, because then also, you know, weekly CQ, the number of issues. Because remember now sicklers live longer because the quality of care is improving. How about this child who is going to be on CQ for a very long time, yet whenever they go to the sickle cell clinic, no one bothers to do their visual acuity and they can end up with a retinopathy. So there are a number of other things that we need to be thinking through as we think about prophylaxis. But like I said, there's a study being done here in Uganda and I think in Mozambique to try and explore other alternatives of the chemoprophylaxis molecules that we can use among sicklers. The immunocompromised people, like people living with HIV, we know very well that they're on cotrimoxazole for some other things, but they're also doing cotrimoxazole for malaria prophylaxis because cotrimoxazole has an anti-malarial effect. Then there's post-splenectomy or HSS patients shall also use monthly. You know, when you don't have you have a splenectomy or you have a big spleen, you need to use an antimalarials. Then it's mandatory that the mobile populations, especially those that are coming to places where there's drug resistance, we want to go into a practice of having them tested for malaria at the point of care, including the migrants. And please note this last bullet: residents living in areas of reduced malaria prevalence of less than 4%, look back at the map, shall take chemoprophylaxis as detailed above when traveling to high transmission areas. We could go back to the map and see, and just look at this, just for us to be very clear. Assuming you're coming from somewhere here, Ankole, and you're going to visit West Nile, these are the people they are talking about. You're coming from maybe Kampala and you're going to check Karamoja. You're coming from Kampala, you're going to check on maybe even if you're going to ideally in the policy we are saying that you should be doing some prophylaxis, chemoprophylaxis. So that brings me to the end of the policy, and now I want to go into guidelines. We started by the guidelines by trying to understand and define what malaria is. Malaria is an acute febrile illness that is caused by an infection with malaria parasite. This illness can range from mild to severe or life-threatening illness. Someone kindly mute, I'm getting interrupted. So key thing here, febrile, acute. Febrile because in most cases the patient will have a fever. A malaria patient normally will be very, very sick. And this fever normally will be less than a few days or less than 14 days or less than 7 days. And for you to say this is malaria in any febrile patient, you must have demonstrated the presence of malaria parasites. That's why the test and treat policy comes in handy. So what is uncomplicated malaria? When you have any symptoms of malaria, or and on top of that, you're having a positive RDT or positive malaria test, but you don't have any sign that indicates severity of vital organ dysfunction, as we shall see in severe malaria. Then there you're dealing with uncomplicated malaria. You have symptoms, you don't have any clinical laboratory signs that indicate severity of vital organ dysfunction, then we are dealing with uncomplicated malaria. But the moment you have symptoms that later progress to clinical or laboratory signs that indicate severity of vital organ dysfunction, on top of the positive BS or malaria RDT, then you're dealing with severe malaria. Then what is malaria treatment failure? The recurrence of fever that is later confirmed by parasthemia, and this should be parasthemia demonstrated by microscopy before 28 days or 4 weeks of treatment. This is malaria treatment failure. However, if it happens after 28 days, it's either a reinfection or recrudescence. Now, how will you differentiate between recrudescence and reinfection? This one in the facility, you can't demonstrate. It can only be demonstrated in one of those big labs where they get assuming they had your parasites before and they have your parasites now, then they do a genotyping to be able to tell whether these are new parasites or these are parasites that hid somewhere in the liver, remobilized and caused you recurrence. So the difference here happens in the days. Less than 28 days, it's a recurrence. After 28 days, it's a reinfection or recrudescence. So what causes malaria? Clearly, you must have any of these species of parasites. The name of the parasite is Plasmodium. It has different species. It has Falciparum, the notorious one. It has Malaria. It has Ovale. It has Vivax. And Noeles. Noeles is in some parts of Africa, but it's not yet here in Uganda. The last malaria indicator survey hardly picked Ovale and Vivax, but it picked some mixed infections of malaria and Vivax, malaria and Ovale, and then malaria alone. But the commonest we have here at 96.9% is Plasmodium falciparum. Remember, this particular species of Plasmodium is very notorious. It's very notorious for especially causing severe disease. I told you last time, why does it do that? It multiplies very, very fast. It affects all stages of red blood cells. And then it causes the red blood cells to be very sticky, and they stick to the walls of the blood vessels, and they interfere with the usual blood flow to vital organs, and that's causing hypoxia, and then the dysfunctioning that you see that will eventually render you as a severe malaria case. This is also very, very important. So how do you get these parasites into your body? What is the mode of transmission? It's commonly from a bite from an infected female Anopheles mosquito. But rarely it can be through blood transfusion, but it can also be to child, that is transplacental vertical transmission. So what happens after the parasites have been transmitted to you? 4 things can happen. If you're strongly immune, for some reason, either because of exposure or because of the sickle cell trait, the following may happen. There will be clearance without causing disease, especially for those with high immunity. So my dear friends here who are on the forum, if you've grown up, you go party, you sleep in the same room with some people, they suffer from malaria. For you, you walk out scot-free. And you think you're just privileged, kindly mind to check your sickle cell status. You could be a carrier, and then in as much as you survive malaria, but you suffer the repercussions of getting another carrier, and then the consequences are not the best. Then there's also asymptomatic parasthemia. Here the parasites are seen, but the person has no symptoms. They're not complaining, but they're a danger to community because they are transmitting to other people. So Then you have uncomplicated malaria as a result. We already mentioned you have constitutional symptoms, but no danger signs. Then severe malaria, you have malaria parasites with features of vital organ dysfunction. So these are the things that can result based on your level of exposure and level of immunity, and whether you have some other things existing, genetic makeup that maybe is protective against malaria. So yes, how do you manage uncomplicated malaria? Key thing is that you need to first of all make a diagnosis. The diagnosis involves history taking, physical examination, and laboratory confirmation. And then after that, you go into treatment. So during the history taking, it's important that you characterize the fever, because the fever of malaria is intermittent. If like for P. falciparum, you'll know that maybe after 48 hours, the fever will come again. And that is why, and then it goes down and it comes again. And why? Because if you look at the cycle of malaria, given the species you're dealing with, there's that cycle that they will move through the merozoites, infect the red blood cells. Then when the red blood cells rupture and the parasites go into blood, that's when you get the fever. And then they do that periodically depending on the kind of species. So for malaria, you have intermittent fevers. Why? Because of the way the parasite behaves when it is whenever it's in the blood system, and then it is released into whenever it infects red blood cells, and then eventually it's released into the blood circulation. Patients' recent activities are very, very important. Like if someone stays in Kampala and then they come back, they go visit somewhere, say maybe in Arua, and then they come back, maybe the entire family visited, and then the next time you see this child, they have a fever, even when they don't have any parasites yet, or maybe they have scanty parasites, but then they have very reduced urinary output, or they are passing tea-colored urine. Be highly suspicious. They went to a high endemic area, maybe did no prophylaxis and didn't use the mosquito net. It's very, very important. Past medical history. Have the patient done any medication, any known chronic illness? Because remember, like we said, the people living with HIV are at high risk of malaria, of frequent episodes of malaria, but also severe malaria. What was the prior treatment? Are there danger signs? Then now you can go into the physical, assessment. Key thing, and this majorly speaks to triage. What's the temperature? Is there hyperpyrexia? Wait, because this is what guides your treatment. What are the vitals like? What is the respiratory rate? Is the patient in respiratory distress? All of us know here how you pick respiratory distress. Look at the patient. Are they laboring to breathe? Is there a nasal flaring? Is there a head nodding? In other words, is there a use of accessory muscles of respiration? Is there a chest indrawing, as is seen by intercostal recession and subcostal recession? Pulse, what is the rate especially? What is the volume? What is the blood pressure for the age of that, according to the age of that patient? It's very, very important. And then now you go to pick the danger signs. Because members here, please note, it's important that we pick and memorize the danger signs. Because the danger sign is a simple thing. It shows you the complication that will make you decide that, yeah, because this complication is present, this is a severe malaria patient, and you don't misdiagnose the patient. So you start by by knowing the sign and being able to pick it in a patient, then it guides you to identifying a complication. Like, for example, I'll clearly tell you that if I'm arriving in an environment and I happen to speak, that will be a sign that I'm present, because for people who know me, they know my voice. So the sign that Jen Nabakooza could be around will be my small voice. So clearly, the sign points you to a complication. So if I'm a complication in the environment, my small voice will be the sign of identifying my presence. And so whoever wants to deal with the problem I cause will come and find a way of evacuating me so that I don't cause a problem. It's simple logic. So here we have the signs listed down: convulsions of fits within the last 2 days or at present. Why are we emphasizing convulsions within the last 2 days, or they are happening at that time or within the last 2 hours? Patient is not able to drink. I'm going to speak to this later. Someone who is vomiting everything, altered mental status, or in form of lethargy, drowsiness, unconsciousness, or confusion, altered mental status. It can be lethargy, it can be prostration, it can be drowsiness, it can be unconsciousness in form of coma, confusion. You ask someone, where are you? I'm in Kampala, yet they are in Jinja. Who is that one? John instead of Jane. What time is it? I'm seeing the lights are on. It's broad daylight. Someone is saying lights are on, and they think it's dark and it's at night. Prostration. Members, let's learn how to differentiate between lethargy and prostration. I think for me, prostration is the extreme of lethargy. For me, when I used to be in the OPD of Kamuli, if I would see this patient who is walking in a little slower than they walk, okay, assuming I knew them, than they usually walk, then this patient is most likely lethargic. But if you saw a patient being brought on a border, and their legs are fixed onto the border, and someone has to sit behind them, and even when they enter into your room, they have to be supported to maybe taking a drink, this patient for sure is in prostration. Severe respiratory distress, I already described this. Severe pallor. Here, don't talk about severe anemia. Here, what you see as a sign is pallor. Then severe dehydration. For example, for convulsions, think about cerebral malaria. Think about hypoglycemia. Think about hypoxemia. All these would give you would be complications of severe malaria, but the sign you pick are convulsions. Not able to drink or feed and vomiting everything. Think about hypoglycemia. Think about electrolyte imbalance. Altered mental status, cerebral malaria, hypoglycemia. Name them. Prostration could be shock, especially if they have cold extremities. Respiratory distress. Think about severe anemia. Think about congestive cardiac failure as a result of severe anemia. Think about pulmonary edema. Think about acidosis. Severe pallor points you to severe anemia. Severe dehydration points you to, it can point you to electrolyte imbalance. So you pick the sign and identify complication. So now we try to do the systemic physical examination. Normally, you will start with a general exam that we saw above, but clearly, depending on where you find most symptoms, you will want to start with that system first. Respiratory distress, you know that you want to listen and see if there is noisy breathing for air obstruction. You want to make sure patient is breathing. You want to make sure that the respiratory rate is okay. Then you want to see if there are no features of distress. Then you auscultate. If you get crepitations, think about pulmonary edema. Cardiovascular system, you want to do the pulse, its rate and volume. Rhythm, maybe if someone has done other medications, like maybe they've tried quinine somewhere, you may want to do rhythm. And then you can listen to the heart. If there's a gallop rhythm, probably the pulse, and then maybe they are also having a tender palpable liver. Probably this person is in failure. Then you can do abdomen exam, skin for dehydration, maybe drug reaction, musculoskeletal system for tenderness, central nervous system. Remember, level of consciousness is very important. Confusion, is there a neck stiffness? Check the reflexes. All these things you have to do. So then further confirm the diagnosis, you'll want to do specific confirmation by doing the rapid diagnostic test. The one that we commonly have is histidine-rich protein 2. This one picks P. falciparum specifically. Then the pan-Aradites pick oleoparasites. Then we have microscope as the gold standard. But please, if you want to type the parasites and quantify, you may want to do a thick or thin film. Then just to rule out other comorbidities, but also maybe if you want to make a diagnosis of a complication like anemia, you may want to do a full hemogram or full blood count. But please be sure that you can interpret the results and make use of them. Then urinalysis can actually help you know if it's a hemoglobinuria or hemolysis or hematuria, or if it's acute kidney injury, early signs, and then blood culture and sensitivity. And then now you want to do treatment.